Welcome back everyone. Today we are going to learn about the abnormalities of serum sodium. So basically the abnormalities of serum sodium are hyponatremia or hypernatremia. Anytime we encounter a situation in which hyponatremia or hypernatremia is found in a child or even an adult, we are confused as to how to approach the case, what might be the specific etiology, and how to manage the child. Not just give a blanket treatment like giving 3% saline for hyponatremia or giving some extra fluid for hypernatremia, rather how to approach. So if we want to learn the abnormalities of serum sodium and how to manage them and how to approach them, this is one basic thing that all of us need to understand. What is that? The thing is that hypokalemia and hyperkalemia are the disorders of potassium metabolism. Similarly, hypocalcemia and hypercalcemia are the disorders of calcium metabolism. But you will think that the hyponatremia and hypernatremia are the disorders of sodium metabolism, but that is not the case. In fact, the hypo and hypernatremia are the disorders of water metabolism. So basically, whenever we encounter hypo or hypernatremia in a child, more often than not, the problem is in the water metabolism in the body, not the sodium handling or sodium metabolism in the body. That is a basic thing that we need to understand if we want to understand the pathophysiology and the probable diagnosis and how to manage a case of abnormal sodium in the body. So what is the outline of discussion for today? We will understand how the body water and electrolyte composition of the body is, what is osmolality and what is tonicity, what is the concept of corrected sodium, how the osmolality and volume are regulated. Then we will learn about the causes of hyponatremia and the causes of hypernatremia and how to approach them, and if possible we'll discuss some case scenarios. So coming to the total body weight and total body water, we know this already that in a term infant, the total out of the total body weight, almost 75% is composed of the total body water, and in older child it assumes the same as adult. That means almost 60% of the total body weight is composed of the total body water. Now, in an adult, that is after puberty, if we compare females and males, the males is 60% of the total body weight is body water in comparison to females, in which almost 50% of the body weight is body water. Why? Why this lesser proportion in females? Because in comparison to males, females have more body fat and less body muscle. Muscle is rich in water. That means the gender which will have higher muscle will have higher body water, and fat is less in water. That means the gender which will have more fat will have less water. That's why as the muscle males have more muscle mass and less body fat, they have more body water, and as the females have less muscle mass and more body fat, they have less water. So conditions that cause relatively decreased total body water. So any condition that will lead to decreased muscle mass will lead to decreased body water. Similarly, any condition that will lead to increased fat, that will lead to decreased body water. So first condition is obesity. Obesity, there is more fat, but fat is less in water. So less water content, that will lead to decrease in body water, total body water. Similarly, dehydration, there is loss of water from the body, so that will lead to relatively decreased total body water. Malnutrition, so loss of muscle mass will be there in malnutrition. So muscle is rich in water, so loss of major water content is there. That's why malnutrition is a cause of decreased body water. How the body water or total body water changes with age, we'll discuss that in detail also, but for now we need to remember that the total body water is composed of two compartments, that is extracellular compartment or extracellular fluid and intracellular compartment or intracellular fluid. Extracellular fluid means the amount of total body water that is remaining outside the cells. Outside the cells means it may remain outside the cell inside the blood vessel, that is plasma, or it may remain outside the cell and interstitial compartment, that means outside the blood vessel also. So that is extracellular fluid. Intracellular fluid, as the name signifies, it refers to the amount of water present inside the cell, that is intracellular fluid. In a newborn, that means a term infant, among the total body water, the ECF composition is higher than the intracellular fluid. But as we know, as the age progresses and the body achieves an adult age, the intracellular fluid compartment becomes higher than the extracellular fluid. That means with the progression of age, the concentration or proportion of extracellular fluid must decrease, and the concentration or the proportion of intracellular fluid must increase. So that is signified here. As the age progresses, the extracellular fluid compartment becomes less and less. That is the proportion of extracellular fluid compartment. The intracellular fluid compartment proportion becomes slightly more, and the total body water decreases from the 75% to 65%, as we saw in the pie charts before. So what are the various compartments of total body water? If we think that this is the total body weight, this chamber or this bottle is the total body weight, out of that how much is the total body water? We learned just now that the total body water is 60%. But if we divide that total body water 60% into two compartments, that is extracellular fluid and intracellular fluid, we just learned that in an adult body the intracellular fluid composition is higher than the extracellular fluid. We can just remember that as two-third, one-third. Two-third of 60% is 40%, one-third of 60% is 20%. So we can just roughly remember that among the 60% that is total body water, 40% is intracellular fluid, that means inside the cell, and 20% is extracellular fluid, that is outside the cell. But if we divide further the extracellular fluid into two more compartments, that is interstitial fluid and plasma, we can remember that this is 3/4 and this is 1/4. So 3/4 of 20% is 15%. So interstitial fluid is 15% and 1/4 of 20% is 5%, that is plasma is 5%. So if we think out of the total body weight, 60% is the total body water. That 60% is divided like this: the intercellular fluid is 40%, the extracellular fluid is 20%, out of which 15% is interstitial fluid and 5% is plasma. So the compartments of total body water just now we discussed is this. If certain conditions will be there which will lead to the loss of plasma component of the body, what are those components? The plasma component can be altered by dehydration, anemia, polycythemia, heart failure, abnormal osmolality, and hypoalbuminemia. Similarly, the interstitial fluid compartment can also be affected by heart failure, liver failure, protein losing enteropathy, nephrotic syndrome, sepsis, ascites, pleural effusion. So basically what I mean to say here is that we need to learn about the different compartments, because a particular pathology may affect one particular compartment of the total body water specifically. So the predominant water loss or the predominant volume loss will be or may be from that one compartment, relatively sparing the other compartment. So the balance of fluid movement inside the body is like this: there is an extravascular compartment and there is an intravascular compartment. In the intravascular compartment, there is oncotic pressure due to proteins and hydrostatic pressure due to the fluid pressure. Similarly, oncotic pressure and hydrostatic pressure are present in the extravascular compartment also, and the balance of fluid movement between the extravascular and intravascular compartment is determined by the balance between the oncotic and hydrostatic pressures. The oncotic pressure predominantly draws water into it, and the hydrostatic pressure predominantly pushes the water out of that compartment. So suppose for example in the intravascular compartment the oncotic pressure will be higher, so it will draw water inside it. And similarly, if the hydrostatic pressure inside the intravascular compartment will be higher, it will push the water outside. So what are the concentration of major cations and anions in the body? For now, think of this as this is the extracellular compartment, and think of this as this is the intracellular compartment. These are the cations, these are the anions. Similarly, these are the cations and these are the anions. So can you tell which is the predominant cation in the extracellular compartment? Yes, you guessed it right. It is sodium, followed closely by potassium, calcium, and magnesium. Similarly, in the intracellular compartment, the predominant cation is potassium, closely followed by sodium and magnesium. Coming to the anion part, the predominant anion in the extracellular compartment is chloride, followed by bicarbonate, followed closely by protein, others, and phosphate. Similarly, coming to the intercellular compartment, the predominant anion is phosphate, followed by protein, bicarbonate, and chloride. We need to remember this major cation and anion concentration in different compartments. Basically, we need to remember what are the major cations and major anions so that we can learn about their metabolism and balance. So various composition of IV solutions, we have commonly these two or three IV solutions: normal saline, N by 2 or half normal saline, N by 5, and Ringer's lactate. I need you to remember about this normal saline. The normal saline contains only sodium and chloride, rest other things are absent, and the sodium chloride composition is 154 millimole per liter, and obviously the chloride composition will be equal to sodium. If it is N by 2 or half normal, obviously the sodium concentration will be 154 divided by 2, that is 77, and obviously N by 5 will be 1/5 of that, so around 34. Ringer's lactate contains sodium around 130, chloride around 109, potassium around 4, calcium around 3, and lactate around 28. Why we need to understand this? I'll tell that in the next slide. So why we need to understand the various electrolyte composition of various body fluids, various IV fluids available, is that because whenever fluid is administered to a patient, that is because we want to compensate or we want to replace the fluid lost from the body. So whenever we are administering a fluid, we have to think that whatever fluid has been lost from the body, the IV fluid we choose for that patient must closely mimic the fluid that has been lost. For example, come to diarrhea. In the diarrhea fluid, on an average, the sodium concentration is around 10 to 90. On an average, it is around 50. The potassium concentration is around 10 to 80. On an average, it is around 50 to 60. The chloride composition is around 90 to 130. On an average, it is around 110. And the bicarbonate concentration is around 40. So, for example, if I want to give IV fluid to a patient suffering from diarrhea, I have to choose an IV fluid which resembles almost this concentration, because if I don't choose an IV fluid resembling this concentration, that might lead to abnormal electrolyte balance. Suppose if I choose a IV fluid that has low sodium content than the diarrhea stool, obviously the patient will have hyponatremia. Similarly, if I choose an IV fluid that has higher potassium concentration than this, the patient may have hyperkalemia. So similarly, I need to choose a fluid which has similar composition to the type of fluid lost from the body. So coming to this example, for example, what is the replacement fluid for diarrhea? So the average composition of diarrhea is sodium content is around 55 milliequivalent per liter, potassium is around 25 milliequivalent per liter, and bicarbonate is around 15 milliequivalent per liter. So these are the common IV fluids available. So think which fluid has almost around 55 milliequivalent per liter and bicarbonate around 15 milliequivalent per liter. Accordingly, we will choose that. So ideal replacement fluid for this solution will be N by 2 D5. Why N by 2? N by 2 contains sodium around 77, that is close to sodium, that is 55. Why D5? Because obviously we have to give the glucose so that the patient doesn't develop hypoglycemia. And potassium 25. If we think N by 2 doesn't have any potassium, so that means we have to add potassium to that. How much? 25. So almost 20 milliequivalent per liter potassium chloride we have to add to that. And if we add sodium bicarbonate of around 30 milliequivalent per liter, it will give rise to, or it will balance the bicarbonate as well. It will add to the sodium content also. So that is the ideal replacement fluid for the diarrhea. Similarly, what is the replacement fluid for emesis or nasogastric losses? Average composition of gastric fluid is 60 milliequivalent per liter of sodium, 10 milliequivalent per liter of potassium, and chloride of 90 milliequivalent per liter. So what will be the ideal replacement fluid? The ideal replacement fluid will be normal saline, because the chloride content is 90. No other fluid has such high chloride content. So we have to give normal saline. Obviously normal saline doesn't have any potassium. The potassium has to be added to that, 10 milliequivalent per liter, and replace output ml per ml every 1 to 6 hours. So this is the basis for choosing a replacement fluid. Similarly, we can see here the ideal replacement fluid for renal output also. So, what is the choice of maintenance fluid in children? Previously, 5, 10 years back, or 15 years back, by default, if suppose a patient has come to us and we don't know how to individualize the fluid therapy for that child, or until the time an individual fluid therapy is prepared for that child, we used to administer a blanket fluid for that child. Suppose what maintenance fluid will give for a child suffering from dehydration or diarrhea or something like that. Previously, it was like that N by 2 D5 used to be used. N by 2 means half normal with 5% glucose. But what happened is that they saw that a lot of children, basically critically ill children admitted to the ICU, developed hyponatremia, which was associated with higher degree of morbidity, higher degree of mortality also. That's why they decided that, or they did randomized control trials and saw that it is better if rather than N by 2 D5, we choose DNS or NS with D5, that is normal saline with 5% dextrose as the ideal maintenance fluid for children, because that will lead to a less incidence of critical illness associated hyponatremia, which is associated with less morbidity and mortality than associated with N by 2 D5. So now gradually the choice of maintenance fluid for children has been changing, or is changing from N by 2 D5 to DNS. So now coming to the concept of osmolality and tonicity. We need to understand what is osmolality and tonicity. Coming to osmolality. Osmolality refers to the property of a particular solution independent of any membrane. That means the property of a particular solution irrespective of what type of membrane is present surrounding that solution. May it be a permeable membrane, may it be impermeable, may it be semi-permeable, it doesn't matter. Whatever solute concentration is present inside a solution, the osmolality is referring to that. For example, if you see type 1 solution here and type 2 solution here, I don't tell you about the membrane properties. I just ask you what is the osmolality of these two solutions, or which solution has higher osmolality. So if you see, the solution 1 has higher concentration of solutes, solution 2 has lower concentration of solutes. It simply means that solution 1 has higher osmolality, solution 2 has lower osmolality. That is all. But coming to tonicity, tonicity refers to the property of a particular solution in reference to a particular membrane. What does it mean? We'll come to that. See this cell or a solution. Imagine this is a cell. The cell is surrounded by a semi-permeable membrane. Semi-permeable means it is not permeable to all the things. That means some things may be able to pass through the membrane, some things may not be able to pass through the membrane. That is meant by semi-permeable. So imagine two solutes, solute 1 and solute 2. So coming to solute 1, as you can see, the solute 1 is not able to cross the membrane. It is bound by the membrane. The membrane is impermeable to the solute 1. That means if solute 1 concentration inside the cell increases and the solute concentration, the same solute concentration, solute 1 concentration outside the cell is less than that in the inside, there is higher concentration of solute inside the cell. So what will you do? It will lead to increase osmolality inside the cell. That means the water will move from outside the cell to inside the cell. That means if a particular solute is contained inside a semi-permeable membrane, that means that solute cannot cross the membrane, it will effectively cause movement of water, or that means transcellular shift of water depending on where the concentration is higher and lower. Water will always move from an area of lower solute concentration to a higher solute concentration, because the water concentration is different. Solute concentration lower outside means water concentration is outside. That's why water is moving from an area of lower solute concentration to a higher solute concentration. That is called osmolar movement of water. But coming to solute 2, you see, solute 2 is able to freely move across the cell membrane. It can move outside the cell, it can move inside the cell. The membrane that is surrounding the cell is actually permeable to solute 2. That means if the solute 2 concentration inside the cell gets higher and the solute 2 concentration outside the cell gets lower, will it cause effective movement of water? The answer is no, because the solute will just go across the concentration gradient and ultimately it will equalize the concentration. That is why the solute 2 will not cause effective or final movement of water across the cell membrane. That means both the solutes will give rise to increased osmolality if the concentration increases, but only one solute will cause effective or ultimate movement of water with its concentration increasing, but another solute will not cause the movement of water with its concentration increasing. So the solute 2 kind of becomes an ineffective osmol. It gives rise to osmolality, but it doesn't give rise to tonicity. That is meant by tonicity. So solute 1 will contribute to the osmolality and tonicity both, because it is not permeable across the membrane, so it will cause shift of water. On the other hand, solute 2 will not contribute to the tonicity. It will only contribute to the osmolality. That's why it is known as ineffective osmol, because it will not cause the shift of water across the cell membrane. That is the difference between osmolality and tonicity. I hope everyone has understood. So imagine this is our cell, and the cell is surrounded by a cell membrane which is semi-permeable. That means it is permeable to water and may or may not be permeable to some solutes. We know the formula for plasma osmolality, that is 2 into sodium. Why 2 into sodium? Sodium plus chloride. To amount for the same number of anions, it is just sodium is multiplied by 2. 2 into sodium plus glucose plus blood urea nitrogen. The division factor is to convert them to millimole per liter. So imagine three things: glucose, sodium, and urea inside the cell. The difference between these three things is that if glucose concentration increases or sodium concentration increases, it is not able to move outside the cell. That's why if glucose concentration increases inside the cell or sodium concentration increases inside the cell, it will ultimately cause shift of water from outside to inside. That means if it is giving rise to osmolality and tonicity also, both. But consider urea can freely move across the cell membrane. That's why urea becomes like solute 2 discussed in our previous slide. So urea is an ineffective osmol, or it doesn't give rise to tonicity. It only gives rise to or contributes to osmolality but not tonicity. So imagine this scenario: if the suppose the concentration of sodium is higher on the outside than on the inside, then where will the water move? Because it is not permeable across the membrane. So ultimately there will be the water will move from an area of lower solute concentration to a higher solute concentration. So ultimately net movement of water will be from inside to outside, so as to increase the or equalize the concentration. Similarly, suppose the glucose concentration increases outside the cell, but the sodium concentration is remaining constant. The glucose concentration is higher on the outside than on the inside. So what will it cause? It will ultimately cause the net movement of water from the inside to the outside. So this net movement of water from the inside to the outside will dilute the glucose, no doubt, but it will also dilute the sodium, which is actually not decreased in this case, but it will appear as if it is decreased because it has been diluted by the net movement of water, which is caused by the sodium, so which is caused by the glucose. So that is the phenomenon where an increase in glucose concentration in the plasma can lead to a falsely low sodium, that is called pseudo hyponatremia. So with every 100 gram per deciliter, 100 milligram per deciliter increase in glucose concentration above a baseline of 100, the sodium appears as if it is falling by 1.6. Suppose at an RBS of 100 milligram per deciliter, the sodium level is 135. So at an RBS of 200 milligram per deciliter, the sodium will appear as if it is 133.4. At an RBS of 300 milligram per deciliter, the sodium will appear as if it is 1.6 less. That means 131.8 or something like that. So with every 100 gram per deciliter increase in glucose concentration, sodium will appear as if it is decreasing by 1.6. It is not actually low, but it will appear low. Why? because what we saw in the previous slide, the water will move from inside the cell to outside the cell so as to dilute the whole compartment, dilute all the constituents that are present inside the compartment. That is leading to pseudo hyponatremia. That's why in a background of hyperglycemia, or in a patient who is having hyperglycemia, like a patient suffering from diabetic ketoacidosis, we need to calculate the corrected sodium, because whatever lab value we will get, that will not be the actual sodium, that will be lower than the actual value. Because lower, why? Because of this phenomenon. So what is the osmolar gap? Osmolar gap refers to the difference between the measured osmolality and the calculated osmolality. How do we calculate osmolality? We just learned the formula, because it is 2 into sodium plus glucose plus blood urea nitrogen. By that we calculate the osmolality. But actually you can measure the osmolality of a particular solution also by this instrument. This is osmometer. So suppose you calculate the osmolality of a solution, it is coming to 90 milliosmol. But you measure the osmolality, it is coming to 92 milliosmol because of some unmeasured osmoles, some osmotic substances which are not included in the formula, that will give rise to unmeasured osmoles. So the difference between the calculated and the measured osmolality is called the osmolar gap. So these are the some of the unmeasured osmoles like ethanol, ethylene glycol, methanol, sucrose, sorbitol, mannitol. These are some of the solutions which can give rise to very high osmolality, which can give rise to high osmolar gap. So what is the osmolar gap? The difference between the calculated and the measured osmolality. Ideally, the calculated and measured osmolality should always stay within 10 milliosmol per kilo. But if it goes beyond 10, that means there is an osmolar gap present due to the presence of some unmeasured osmoles in an increased amount. So what are those unmeasured osmoles? These are the unmeasured osmoles. Now coming to the same explanation, same concept of pseudo hyponatremia, but some different conditions. To understand that, you need to understand this. So suppose this is the whole blood compartment. Out of the blood compartment, suppose the hematocrit is around 55. So this is the hematocrit. What is the rest amount? This is the plasma. Blindly we think that the plasma is only water, but actually not, that is not the case. The plasma constitutes water mainly, with some minor amount of solid, that is this much. The water is almost 93% and the solid is almost 7%. The electrolytes that are dissolved, mainly sodium, we can think of mainly sodium. The sodium is mainly dissolved in the water compartment. Obviously it will not be dissolved in the solid. And the sodium concentration actually refers to the concentration in the water compartment, because there is no sodium in the solid compartment. So whenever we are measuring, or whenever you are referring or thinking about active sodium in the plasma, it is referring to the sodium dissolved in the water compartment. But the problem is, whenever we measure serum sodium by an indirect ion electrode method or indirect method, the serum sodium, that the value that comes is calculated based on the whole plasma compartment, whole 100%, not just the 93%. For example, imagine this. Imagine that this is 100 ml. Out of that, 93 ml is water and solid is 7%, and the sodium present is around 31 gram. Imagine that. So 31 gram sodium present in 93% water, that means 1 by 3, almost 93 ml water, that means every 3 gram or 3 ml of water contains 1 gram of sodium. Suppose some phenomenon happens which will lead to the increase in solid compartment, but the water compartment remains the same. That means the sodium present here is around 20 gram, or 25 gram or something like that. So as you can see, the electrolytes are equally spaced. That means the concentration of sodium in this water is same as the concentration of sodium in this water. But whenever we measure by the indirect method, the value that will come according to the total 100 ml, according to the total 100 ml. So the total sodium present in this 100 ml has decreased. Although the concentration has remained same, the total sodium has decreased. So it will appear as if the sodium is less. but actually the sodium concentration is not less, the total sodium amount is less, but in the laboratory parameter it will appear as if it is less. So that is called pseudo hyponatremia. But here the pseudo hyponatremia, why it is pseudo? Because there is no actual low sodium, the sodium is appearing low because of the increase in solid component of the plasma. The solid component is mainly composed of protein and lipid. So any parameter or any pathology that will give rise to increased protein or increased lipid component like hypercholesterolemia or hypertriglyceridemia or paraproteinemia or intravenous immunoglobulin administration, those phenomena can lead to increase in solid compartment, and that can lead to a phenomenon of pseudo hyponatremia. That means the total sodium will be less, but the sodium concentration or functional sodium will be the same. So how the regulation of osmolality and volume occurs? Two things are regulated in our body which regulate or which decide the sodium functioning. One is the system of water balance which determines the osmolality. One is the system of sodium balance which determines the intravascular volume. How they are regulated we'll learn now. So we'll learn how the osmolality is regulated. The normal plasma osmolality is 285 to 295 milliosmol per kg. The modification of water intake and excretion is the main mechanism by which the osmolality is regulated. So think, what are the sources of water intake for the body? Water intake means whatever water we are drinking, that is one source of intake, and whatever water is produced from oxidation inside our body, that is one source of input of water inside our body. Similarly, what are the sources of water output? One is the urine output that we are excreting, and another is the insensible water loss from the skin, lungs, and GI tract. So, two sources of input. One is water intake, another is water produced from oxidation, out of which we can control only one thing. We can regulate the water that we are intaking or that we are drinking. We cannot regulate the water that is produced inside our body at the cellular level. Similarly, among the output, we can only regulate the urine output. We cannot regulate the insensible water loss that is occurring from the skin, lungs, and GIT. So how the osmolality is regulated? The osmolality regulation mainly happens by the osmoreceptor present in the hypothalamus. This is an osmoreceptor. The osmoreceptor mainly gets stimulated by two stimuli. So you need to remember those two stimuli. The main stimuli is increase osmolality, and second stimulus is decrease in effective vascular volume or effective circulating volume. So whenever there will be increased osmolality in the plasma, or whenever there will be decrease in an effective circulating volume, the osmoreceptor will get stimulated. So upon getting stimulated, what will the osmoreceptor do? The osmoreceptor will produce ADH. ADH means antidiuretic hormone. So what will the ADH do? The ADH will go and bind to the V2 receptor on the collecting duct. Where is the V2 receptor present? It is present in the renal collecting duct. V2 means vasopressin, which is another name of ADH. So it will attach to the V2 receptor. Upon attaching to the V2 receptor, the V2 receptor will get stimulated, and what will it do? It will insert, or it will cause the insertion of aquaporin 2 channel inside the or in the membrane of the collecting duct, cell membrane of the collecting duct. So upon insertion of aquaporin 2 channel, what will happen? Aquaporin, that means it is regulating water. So water will get reabsorbed from inside the lumen to the body. Water will get reabsorbed. That can be remembered by what is this? ADH, antidiuretic hormone. Antidiuretic hormone means it will cause antidiuresis. Antidiuresis means it will cause less urination. So less urination, how? It will cause reabsorption of water. So the water is being reabsorbed through the aquaporin 2 channel from the luminal side to the body or to the vessels by the V2 receptor, which is getting stimulated by the ADH, which is being secreted from the osmoreceptor, which is stimulated by the increased osmolality or decreased effective circulating volume. So as the water gets reabsorbed, there is a reabsorption of water, which will lead to increasing concentration of the urine and decreasing water excretion. This is one mechanism or one action of osmoreceptor stimulation. There is another action also, number two. What is that? Stimulation of thirst. So basically, whenever there is an increased osmolality in the body will do what? Body will try its best to decrease the osmolality. So how will the osmolality get decreased? By reabsorption of water. So reabsorption water is happening through this renal mechanism. What is the other method by which the osmolality can be decreased? If we drink more water, the water content of the body will increase. So by stimulation of thirst also same thing is happening. Similarly, when there will be decreased effective circulating volume, body will try to do what? Increase the effective circulating volume. So how it will increase the effective circulating volume? By reabsorption of water and by stimulation of thirst. So those are the main stimuli for this osmoreceptor, increasing osmolality and decreasing effective circulating volume. It is important to remember that there are many other stimuli for this osmoreceptor stimulation like infection, medications, nausea, vomiting, pain or stress, and hypoglycemia also. All these stimuli can cause stimulation of the osmoreceptor also. Upon stimulation, these two actions happen. One action is ADH secretion, another action is stimulation of thirst. So as the ADH secretion increases, as the osmolality increases, the ADH secretion also increases. So conditions that can limit the kidney's ability to excrete water. We learned that when the ADH is getting secreted, it is causing the kidneys causing the kidney to retain more water. That means decrease the excretion of water. So what are the various factors that can limit the kidney's ability to excrete water? Syndrome of inappropriate ADH secretion, low GFR, limits of urine osmolality, and volume depletion. We'll learn about all this later. So how the volume is regulated? We learned now how the osmolality is regulated. Second thing is how the volume is regulated. Whenever there will be decrease in effective circulating volume or effective intravascular volume, one thing will happen is that it will stimulate the osmoreceptor. We learned that. What is the another mechanism? This effective intravascular volume decrease will stimulate the juxtaglomerular apparatus to secrete the renin. This renin will convert the angiotensinogen into angiotensin 1, and the angiotensin 1 will get converted to angiotensin 2 by the angiotensin converting enzyme that is present in the lungs. This angiotensin 2 has three actions. It is the strongest vasoconstrictor in the body, so it will cause vasoconstriction. So what will the vasoconstriction do? The vasoconstriction will maintain the necessary pressure that is required to maintain the perfusion of vital organs in a background of effective intravascular volume. So this is being maintained by this. Next, what will the angiotensin do? It will stimulate the proximal convoluted tubule to increase the sodium reabsorption. As the sodium will get reabsorbed, equiosmolar amount of water will also get reabsorbed. So that will help to retain or normalize the effective intravascular volume. What is the third action? It will stimulate aldosterone secretion. Aldosterone secretion by the adrenal gland will occur, and as we all know, aldosterone causes sodium reabsorption in the distal convoluted tubule and collecting duct, which is usually accompanied by potassium and proton excretion. So that will lead to this amount of sodium reabsorption, and obviously equiosmolar amount of water reabsorption will lead to increase in the effective intravascular volume back to the baseline. So decrease in effective intravascular volume will cause all this mechanism leading to all this, so that the effective intravascular volume can go back to normal. So how the kidney regulates the volume? The kidney is the main regulator. Normal fractional excretion of sodium is less than 1%. It can change according to the pathologies. Effective intravascular volume. What is this decrease? Effective intravascular volume. Intravascular volume means whatever volume is present inside the vessels. But effective intravascular volume means volume status sensed by the body's regulatory mechanisms. For example, in a normal person who is having a normal heart, normally functioning heart, the normal intravascular volume is there, which is also effective intravascular volume. But suppose a patient is having heart failure, in spite of that same patient having normal intravascular volume, the effective intravascular volume is decreased. Why? The heart is failing. That means the heart is not able to pump the blood adequately. That means the adequate blood is not being sensed by the sense organs or regulatory organs inside the body. That means intravascular volume is normal or may be normal, but effective intravascular volume is low in a patient of heart failure. So that is one example of what is effective intravascular volume. RAS system we learnt about. This is renin angiotensin aldosterone system. We obviously know about atrial natriuretic peptide. Atrial natriuretic peptide is secreted by the atria of the heart in response to the volume stretching or blood stretching the walls of the atria. Whenever there will be increase in intravascular volume, body will try to decrease it to baseline. So what will happen? Increase in intravascular volume will stretch the walls of the atria more, which will secrete the atrial natriuretic peptide. Natriuretic peptide will cause natriuresis. Natriuresis means sodium excretion. Obviously water will get excreted with the sodium, that will lead to decrease in intravascular volume back to the baseline. So in ANP is secreted by or in response to increase intravascular volume, which will cause decrease in intravascular volume back to baseline. And obviously we know that chronic kidney disease and acute glomerulonephritis have an impaired ability to excrete sodium. We'll learn about that later. So what are the conditions causing volume overload? We learned that how volume is regulated. So obviously volume overload will happen in all those conditions in which the sodium intake is more than the output. That means if intake will be more, output may be normal, volume overload can happen. If intake is normal but output is less, also in that condition volume overload can happen. For example, renal failure. Renal failure, there is impaired ability of the kidneys to excrete sodium. That means the output is less, that will cause volume overload. Aldosterone excess will cause increased sodium retention. That means the sodium output is less, that will cause volume overload. Glomerulonephritis similarly will cause volume overload. Renal retention of sodium during a volume depletion can also cause volume overload. On the contrary, what are the conditions which will lead to volume depletion? Sodium loss more than intake. Whenever there will be sodium loss is more than the intake, there will be volume depletion. That means if intake is less or loss is more, it will cause volume depletion. Gastroenteritis, loss is more. Burns, loss is more. Cystic fibrosis, loss is more, specifically through the sweat. Vigorous exercise, loss is more. Renal sodium losses like tubular disorders or dysplasia. Absence of aldosterone, loss is more. So all these conditions in which sodium loss is more than the intake will lead to volume depletion. So how the renal kidney handles the volume and sodium? Kidney handles the water by which is regulated mainly by plasma osmolality and effective plasma volume, but the kidney regulates sodium mainly by the effective plasma volume. So basing upon whatever knowledge we acquired till now, now we'll learn about hypo and hypernatremia. If you have understood all this that we discussed till now, it will be very easy for you to understand the concept of hypo and hypernatremia, how this happens, how to manage. So coming to sodium metabolism, as we all know, the principal determinant of extracellular osmolality is the sodium because it is the principal extracellular cation. It is necessary for maintenance of intravascular volume. Total body sodium content more than 40% is present in the bone, less than 3% is intracellular, it is negligible intracellular, and the rest amount is present in the interstitial and intravascular spaces. The intake depends mainly upon the diet. The more we intake, the more total body sodium will be, and the sodium is readily absorbed throughout the GIT. That means absorption is not an issue. If we intake more, all of that will get absorbed. The normal serum level is 135 to 145 milliequivalent per liter, and the daily requirement is 2 to 3 milliequivalent per kg. We all know, I hope we all know this channel since our MBBS days. This is the sodium potassium ATPase, which causes shift of 3 molecules of sodium from inside to outside the cell, and the shift of 2 molecules of potassium from outside to inside the cell, so that the principal extracellular cation is sodium and the principal intracellular cation is potassium. How the sodium is excreted? The sodium is predominantly excreted through stool, sweat, and urine, but the urine is the predominant route of excretion. Normal sweat excretion is 5 to 40 milliequivalent per liter, but it can increase in some conditions like cystic fibrosis, in which it is more than 60. Aldosterone deficiency. Aldosterone helps to retain the sodium. So when there will be aldosterone deficiency, sodium will be excreted. And pseudo hypoaldosteronism. That means when aldosterone is functioning less or there is resistance to aldosterone also, in those conditions sodium excretion will be more. Similarly, stool normally minimal around 50 milliequivalent per liter is the normal stool consistency or normal stool sodium concentration. But if diarrhea is present, even more can get excreted, but the predominant excretion route is the urine. So how the sodium and water balance are related? Imagine this is the baseline. Suppose there occurs increase in serum sodium. Increase in serum sodium means, imagine the osmolality and tonicity slide we discussed. Osmolality means any solute that will get increased will give rise to increased osmolality. In addition to that, the cell membrane is impermeable to sodium, so it will also give rise to the tonicity. That means whenever the sodium concentration will increase in a plasma compartment or anywhere in the plasma, the osmolality and the tonicity both will get increased. Now imagine the osmoreceptor slide. Whenever there will be increased osmolality, there will be it will be sensed by the osmoreceptors in the hypothalamus. The two things the osmoreceptors were doing: one thing they were doing is they were increasing the ADH secretion, second thing they were doing is they were increasing the or stimulating the thirst. ADH will cause what? Water to be retained inside the body. Thirst will cause what? Water to be intaken more, or water to be inside water. The patient will drink more water, so the water will get retained inside the body. So this amount of increased water inside the body will cause what? Will cause dilution of the sodium that is present inside the body. So the sodium that has increased from the baseline, now it will fall back to baseline. So all these regulatory mechanisms will help in correcting the increasing sodium back to the baseline. So that's how the sodium and water balance are interrelated. So now comes a critical question. We learnt that osmoreceptor is stimulated by two main stimuli. One was increasing osmolality, one was decreasing volume or decreasing effective circulating volume. But imagine a scenario. Suppose a scenario is there in which the osmolality is less and the decreasing effective circulating volume is also there. That means decreasing effective circulating volume should ideally stimulate the osmoreceptor, and decreasing osmolality should ideally inhibit the osmoreceptor. So two contrasting stimuli are present for the osmoreceptor. The osmoreceptor will give preference to which one? The osmoreceptor will get principally activated or inhibited by which one? Which one is more important for our body? So that is the point of this slide, that whenever there will be volume and osmolality imbalance or volume and osmolality mismatch, the body will always give preference to volume depletion. That means if a person is having decreasing effective circulating volume, which should stimulate the osmoreceptor, and having also low osmolality, which should inhibit the osmoreceptor will get stimulated because of the volume preference. Similarly, suppose a person is having increasing effective circulating volume, which should inhibit the osmoreceptor, and simultaneously having increasing osmolality, which should inhibit the or it should stimulate the osmoreceptor. The osmoreceptor will get inhibited here because the volume part will always get preference over the osmolality. That means the volume regulation gets preference over osmolality regulation. That is the point of this slide. So now coming to hyponatremia. So what is hyponatremia? The normal serum sodium level was less than or 135 to 145 milliequivalent per liter. So whenever the serum sodium will be less than 135 milliequivalent per liter, it will be called as hyponatremia. Hyponatremia can be divided into mild, moderate, and severe depending on the levels. Less than 130 to 134 is mild, 120 to 130 is moderate, and less than 120 is severe. It can occur with a low, normal, or high total body sodium and low, normal, or high total body water. What is that? We'll discuss that in a minute. Always we have to rule out pseudo hyponatremia first. Whenever we encounter a case of hyponatremia, always you should ensure that this is actual hyponatremia and not pseudo hyponatremia. What is pseudo hyponatremia? We discussed two scenarios before. One is the glucose concentration was increasing. Remember that slide? The glucose concentration was increasing, which was causing transcellular shift of water from the inside the cell to outside the cell, which was diluting the sodium which was present outside the cell, appearing as if the sodium is falsely decreased. So in that case, imagine that was pseudo hyponatremia. Another thing is we have to always rule out hyperosmolality. Just now we discussed hyperglycemia, mannitol, sucrose, glycine. These are some of the conditions in which the osmolality will be higher, which will inherently cause, or which will in turn cause the sodium to be appearing falsely low. So in pseudo hyponatremia, the measured osmolality will be normal, and in hyperosmolality, measured osmolality will be higher. But in actual hyponatremia, the measured osmolality should be low. Imagine the formula is 2 into sodium plus glucose and blood urea nitrogen. That means if actually the sodium is less inside the body, the formula will give a lower amount or lower value. That means in actual hyponatremia or true hyponatremia, the sodium osmolality or the plasma osmolality should be low. If in a case of hyponatremia, the plasma osmolality is normal, it is pseudo hyponatremia. If plasma osmolality is higher, it is due to hyperosmolarity, giving rise to a false serum sodium, false low serum sodium. So the classification of hyponatremia is based upon the volume status. It can be hypovolemic, hypervolemic, or euvolemic. So coming to hypovolemic hyponatremia. Hypovolemic hyponatremia, the name itself suggests, obviously there is hyponatremia, but the volume is also low. So imagine a condition in which the sodium is also low, but the volume is also low. That means the volume water loss may or may not be there, but the sodium loss is definitely there. That's why the sodium is decreased inside the body. So what are the conditions, or what are the mechanism? When there will be sodium loss, there will be accompanied by volume loss, because sodium cannot get excreted fresh from the body or in situ directly from the body. We cannot excrete salt crystals. Always we have to excrete, or always we have to lose sodium from the body, means it has to be diluted or it has to be dissolved in water. That means whenever sodium loss will occur from the body, it will be accompanied by some volume loss. And if volume loss occurs from the body, all the compensatory mechanisms we discussed will cause what? Renal retention of water by ADH secretion and all those things. Renal retention of water will be there, less GFR will be there, which will lead to less urine formation. All those things will cause water retention inside the body. So water and sodium both are getting excreted, but the water is only retained, sodium is not retained. So that's why hyponatremia will happen. That means water plus minus it is getting balanced, but the sodium is still low. So that's why it is hyponatremia is happening. So that is called hypovolemic hyponatremia, because ultimately some amount of water is lost, but a lot of amount of sodium is lost. So what are the conditions causing hypovolemic hyponatremia? First thing, hypovolemic hyponatremia means we learned that sodium and water is lost from the body. So that sodium and water is lost from the body by which route? It can get lost by kidney, or it can get lost by somewhere except the kidney or somewhere other than the kidney. That means we can classify the sodium and water loss from the body as two types. It may be extrarenal loss of sodium and water, it may be intrarenal or renal loss of sodium and water. So first coming to extrarenal loss, imagine extrarenal loss means prototype is GI. So suppose sodium and water is getting lost from the body by the GI tract. So what will happen? The compensatory mechanisms will work. The compensatory mechanisms will always try to prevent, okay, sodium is getting lost from the body, so I will not lose more sodium. I will try to preserve some amount of sodium so that the sodium doesn't fall inside the body. So what will happen? The sodium excretion inside the urine will get decrease and decrease and decrease. So the sodium excretion inside the urine, or sodium excretion by the urine, will be low. That means the urinary sodium excretion will be less than 10 milliequivalent per liter. In which scenario? In which the original sodium and water loss is by extrarenal mechanism, the renal compensation causes the urinary sodium excretion to be less. That will lead to urinary sodium of less than 10 milliequivalent per liter. So what are the extrarenal causes of sodium loss and water loss? So imagine sodium and water both are getting lost by the GI tract. So what may be the conditions? Diarrhea or vomiting, intravascular volume depletion, sweating, third space loss, and all those things. Similarly, so imagine all similarly we can imagine, now we discussed extrarenal loss. Now we'll come to renal loss. So sodium and water both are getting lost, but by the renal route. So sodium and water both are getting lost by the renal route means the urinary sodium will be what? Urinary sodium will be high. Urinary sodium will be why? Why? Because the original sodium and water loss is happening through the kidney only. That's why the hyponatremia has happened. The primary loss is due to the kidney. That's why the urinary sodium will be more than 20 milliequivalent per liter. So what are the conditions? Imagine diuretics. If you give diuretics, obviously that will lead to more sodium loss. Osmotic diuresis, conditions in which the urinary osmolality is higher. That's why the diuresis is happening, like decay or renal failure. Post obstructive diuresis, polyuric phase of acute tubular necrosis, juvenile nephronophthosis or autosomal recessive polycystic kidney disease, tubulointerstitial nephritis, cerebral salt wasting, obstructive uropathy, and proximal renal tubular acidosis. Basically, any pathology causing renal loss of sodium and water. That's why we discussed that there are mainly two mechanisms of hypovolemic hyponatremia. Primary mechanism is sodium and water loss, but that sodium and water loss can happen by renal route or by extrarenal route. If the renal route sodium and water loss is happening, the urinary sodium will be more than 20. If the extrarenal route sodium and water loss is happening, the urinary compensation will be there so that the urinary sodium will be less than 10. So these are the causes of hypovolemic hyponatremia. So now coming to what is hypervolemic hyponatremia. Hypervolemic, the name itself signifies there is increase in total body water more than the increase in sodium. That means total body water is getting increased, which is diluting the sodium present inside the body, which is leading to a hypervolemic hyponatremia. So I think this is the easiest mechanism to remember, because whatever condition will cause increased retention of water inside the body will dilute the sodium present in the body, and in turn will cause hyponatremia. So what is the mechanism? Whenever there will be third space loss, vasodilation, poor cardiac output, etc., it will lead to decrease in effective circulating volume. That decrease in effective circulating volume will cause secretion of ADH and aldosterone. The LDH, ADH and aldosterone will cause water intake and sodium intake, and the ADH prevents the extra water loss. So basically water is getting retained inside the body. So why the water is getting retained inside the body, what will the water retain inside the body will cause? It will dilute the sodium, so that the hyponatremia will happen. So what are the conditions? Heart failure, water is getting retained inside the body, fluid accumulation. Cirrhosis, liver failure, water is getting retained inside the body. Nephrotic syndrome, water is getting retained inside the body. Acute and chronic kidney injury, water is getting retained inside the body. Capillary leak caused by sepsis, there is vasodilation, third space loss, water is getting retained inside the body. Protein losing enteropathy, water is getting retained inside the body due to decreased oncotic pressure. So basically all the conditions causing water retention, causing edema, causing fluid retention will cause hypervolemic hyponatremia. Hypervolemic, why? Because the water is getting retained. So in all these conditions, imagine the sodium is low, so obviously the body will try that the sodium will get excreted less from the body, so that the sodium concentration in the body will get maintained. Suppose my normal sodium was 135, now due to hypervolemic hyponatremia my serum sodium concentration is 130. What will the kidney do? The kidney will decrease urinary sodium excretion, so that the sodium will get preserved and the body sodium concentration will get maintained. So what does that imply? That means the urinary sodium will be less than 10, except in one scenario. All these conditions of hypervolemic hyponatremia will have urinary sodium less than 10, except in one condition, in which, why the urinary sodium of less than 10 happens? Because of renal compensation. But if the kidney is damaged itself, can this compensation happen? The kidney is damaged, that's why it cannot retain the sodium like this, and also it causes fluid accumulation inside the body. So that is the exception. That means renal failure is a cause which will cause hypervolemic hyponatremia, but the urinary sodium excretion will be more than 10 or more than 20. So that is one exception. Now coming to the third mechanism, that is euvolemic hyponatremia. Euvolemic, that means the name itself signifies there is no evidence of volume overload or volume depletion. No evidence of volume overload and volume depletion means how the hyponatremia will happen? There will be excess total body water will slight decrease in total body sodium. That will lead to hyponatremia. So the prototype condition of euvolemic hyponatremia is syndrome of inappropriate ADH secretion or CR. So why the syndrome of inappropriate ADH secretion is named like this? What is inappropriate about this? We learned, imagine that slide. We learned about that ADH is getting secreted from the osmoreceptor in response to two stimuli, either increasing plasma osmolality or decreasing effective intravascular volume. So whenever there will be increase in plasma osmolality or decrease in effective intravascular volume, the ADH will get stimulated. That means whenever there is decreased osmolality or increasing effective intravascular volume, the ADH ideally should not get excreted. That is the appropriate response of the body. But imagine there is decreasing plasma osmolality or increasing effective intravascular volume, but still the ADH is not getting inhibited, rather getting secreted. So that means this response is appropriate or inappropriate? This is inappropriate. So that is the inappropriateness of this condition. If the ADH is not getting inhibited by the decreasing osmolality or expanded intravascular volume, gets stimulated and stimulated and stimulated, that is caused, or that is causing the condition syndrome of inappropriate ADH secretion or SIAD, that is classically caused by pathologies in the CNS, pathologies in the lungs, and pathologies like malignancy, like CNS tumor, trauma, hemorrhage, meningitis, all those things, infections, lungs malignancy, lungs mass, lungs infection, all those things, and malignancy. So these are the conditions which will lead to syndrome of inappropriate ADH secretion, which is the prototype example of euvolemic hyponatremia. There is excess total body water. How the excess total body water happens? ADH will cause water retention. We learned that in the slide. ADH will cause water retention. Sodium may or may not be lost from the body, but the excess body water will dilute the sodium present inside the body and will cause the effective sodium concentration to get decreased, so that the euvolemic hyponatremia will happen. What are the other causes of euvolemic hyponatremia? Drugs like MDMA, opiates, antiepileptics, mainly in the pediatrics. We need to remember carbamazepine, oxcarbazepine, and valproate, and all these drugs like TCA, SSRI, vincristine, and cyclophosphamide. Similarly, there is a phenomenon known as NCR, nephrogenic syndrome of inappropriate antidiuresis. That means X-linked gain of function mutation of ABPR2 or V2. Imagine that slide again. The ADH was acting at the V2 receptor of the collecting duct. That's how the V2 receptor was getting stimulated. It was causing the insertion of aquaporin 2 channel inside the membrane, which was causing the retention of water. Now imagine there is no ADH there, but the V2 receptor is constitutively active. Why? Because the V2 receptor has had a gain of function mutation. So obviously it will always act as if it is stimulated. It will always insert the aquaporin 2 channel inside the membrane, and the water will get retained. Water will get reabsorbed irrespective of the ADH being present or not. Rather, when the ADH is not present also, the V2 receptor is always activated due to the gain of function mutation. It is causing aquaporin 2 channel insertion or retention of water. So that is due to problem where? In the kidney, because V2 receptor is present in the kidney. So this is the same pathology as SIAD, but the pathology is not in the CNS, rather the pathology is in the kidney. That's why it is called nephrogenic SIAD, nephrogenic syndrome of inappropriate antidiuresis. That is meant by X-linked gain of function mutation in ABPR2 or V2. Another condition is desmopressin acetate. Obviously, if we give ADH from outside, external ADH, that will mimic as if there is ADH excess, so that will cause the same hyponatremia by the same mechanism as the CAD. Only here the ADH was internally produced, here the ADH is given from outside. Glucocorticoid deficiency causes increased ADH, so same mechanism. Hypothyroidism causes inappropriate renal water retention and causes euvolemic hyponatremia. And there is iatrogenic, that is inappropriate ADH production plus hypotonic fluid administration. So euvolemic hyponatremia, there will be no evidence of volume overload or volume depletion. That's why the name euvolemic. Obviously, the excess total body water and decrease in total sodium body sodium will be there. Some other causes are water intoxication. Imagine there is water intoxication, means excess body water is there. Someone has taken a lot of water or someone has drank a lot of water, and the kidney's ability to excrete the water is less. That means that excess amount of water that the person has taken will get retained inside the body. So it will dilute the sodium and it will cause euvolemic hyponatremia. So what are the conditions in which water intoxication can happen? It may be iatrogenic, that means maybe you have administered by IV fluid the dilute distilled water or something like that. or pure dextrose. If you feed an infant with excess water products, if some child is taking swimming lessons and is swallowing a lot of amount of water, there is tap water enema. In some practices, tap water is sometimes used as a method of enema, so that tap water will get absorbed and it will cause dilutional hyponatremia. Child abuse, if someone feeds excess amount of water as a method of child abuse. Psychogenic polydipsia, someone is taking or drinking a lot of water due to some reason, psychogenic polydipsia, that water gets retained inside the body and the sodium gets diluted. And diluted formula, if you dilute the formula, suppose the formula is to be diluted 30 ml with one scoop of formula, but if you prepare it by suppose one scoop in 100 ml, so that excess amount of water dilutes the sodium. And beer potomania, in some conditions, in some cultures, children are fed with a lot of beer, and the beer is a poor source of sodium and protein, so that will cause hyponatremia. And it may be exercise induced also. Suppose marathon runners or exercise people who do a lot of exercise, they will drink only water without electrolytes, so that amount of water is retained inside the body, and the prolonged exercise is causing the sweat loss, sodium loss by the sweat. So sodium is getting lost, water is getting retained. That means euvolemic hyponatremia will be there. So what are the clinical manifestations of hyponatremia? Imagine this is the brain cell, and suppose hyponatremia will happen. That means outside the brain cell, the sodium concentration is less. Sodium concentration is less means what will happen to the osmolality? Obviously, the osmolality will be less. So the osmolality will be less means water will move from where to where? Water will move from an area of low osmolality to a high osmolality. That means the water will move from an area of low osmolality to a high osmolality. So what will that cause? From outside to inside the cell, the water is moving. That means it will cause the cell to swell. That means all the clinical features of hyponatremia will be predominantly same as cerebral edema. Cerebral edema will be there because of brain cell swelling, that will lead to the increased intracranial pressure. The cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So intracranial pressure increase in means mean arterial pressure minus increase intracranial pressure. That means the cerebral perfusion pressure will decrease. Cerebral perfusion pressure will decrease means the brainstem herniation and apnea may happen. Similarly, other clinical features are anorexia, nausea, emesis, malaise, lethargy, confusion, agitation, and headache, seizures, command, hyporeflexia, dilated pupils, anisocoria, hypothermia, chin stroke respiration, muscle cramps, weakness, and rhabdomyolysis. There are mainly all these features are non-specific. What you need to remember is that mainly three things. One is cerebral edema, mechanism I have explained here. Second thing is hyporeflexia. You need to remember that hyponatremia causes hyporeflexia, hypernatremia causes hyperreflexia. Third thing you need to remember is that when the cell will swell, there is a chance that the cell may swell so much that the cell will get lysed or the cell will break down. Cell will break down means all the intracellular components will get released outside. That will cause muscle cramps, rhabdomyolysis. This you need to remember. So how the hyponatremia is diagnosed? Obviously, the first and most important step is the history. If there is a history of volume depletion like diarrhea or diuretic use, we need to remember that. There is polyuria or salt craving in some conditions of primary kidney disease or aldosterone deficiency, that may point to the diagnosis. Signs and symptoms of hypothyroidism or adrenal insufficiency, that means other signs and symptoms may point towards the diagnosis. And when there will be brain injury, there will be high chance of CAD and cerebral salt wasting syndrome. And when the patient's intake of water, sodium, and protein is documented, that will help us in our diagnosis. Because suppose the patient's water intake is much more, like psychogenic polydipsia, or sodium intake is much less, that will lead to hyponatremia, and the cause is clear from here. After the history, if nothing is suggestive there or nothing particularly suggestive there, we need to proceed to the next step in diagnosis. That is, the first step is plasma osmolality estimation. Why the plasma osmolality estimation? because we know that all the effects of hyponatremia, like the diagram we discussed, all the effects of hyponatremia, cerebral swelling, brain swelling, were happening predominantly. Why? Because the sodium concentration was low, that's why the osmolarity was low, that's why the transcellular shift of water happened. That means all the clinical effects of hyponatremia are due to the low osmolarity only. If there is no low osmolarity, a clinical feature should not happen. That is the first step, that is the most common thing to know. That's why the first important step is to know the plasma osmolality, because in a case of actual hyponatremia, the plasma osmolality should be low, because the osmolality formula itself says that osmolality is equal to 2 into sodium. That means if sodium will be less, osmolality will be less. That means if in the presence of hyponatremia, the osmolality is neither normal or higher, this may not be a case of true hyponatremia. We have discussed this again, we have discussed this before also. Without low osmolality, no intracellular water shift, no symptoms. So plasma osmolality must be low in a case of true hyponatremia. Rather, if the patient having hyponatremia is having normal osmolality, it may be a case of pseudo hyponatremia. If a patient having hyponatremia is having high osmolality, this hyponatremia may be due to osmotic substances like glucose, mannitol, and other osmotically active solutes that we discussed in our diagram and animations and all. And if in presence of true hyponatremia, if true hyponatremia is present there, the osmolality will actually be low. That's why if we get a case of hyponatremia, our first step is always after history taking to measure the plasma osmolality, because that will guide us towards whether this is a case of pseudo or false hyponatremia or it is a case of true hyponatremia. If low osmolarity comes, we need to evaluate further. Exceptions are true hyponatremia plus normal or high osmolarity, that is urea. We'll discuss that. So what is the second step? We have to evaluate the volume status, because we learned that in hyponatremia is classified mainly three types: hypovolemic, hypervolemic, and euvolemic. So how can I know it is hypovolemic or hypervolemic or euvolemic? By the volume status. So that is the second step. First step was plasma osmolality estimation. So can be hypovolemic, hypervolemic, or euvolemic. If hypovolemia, how will know? The signs of hypovolemia will be there. What are the signs of hypovolemia? Signs of dehydration, tachycardia, hypotension, thready pulses. These are the signs of hypovolemia. Similarly, what are the signs of hypervolemia? Edema, ascites, pulmonary edema, pleural effusion, hypertension. All these are features of hypervolemia. If a patient is having neither the features of hypovolemia nor the features of hypervolemia, then the patient might be euvolemic, and the patient's hyponatremia may be euvolemic hyponatremia. So imagine, if hypervolemic hyponatremia, we discussed that all the causes of hypervolemic hyponatremia were having what? Excess of total body water or excess of fluid retention inside the body, so that the sodium was getting diluted. And there was one exception in which the urinary sodium was high, that was renal failure. All the other causes of hypervolemic hyponatremia, we are having less urinary sodium or urinary sodium less than 10. So that's how we distinguish between all those. If urinary sodium is less than 10, all those other conditions were there, like cardiac failure or nephrotic syndrome or cirrhosis and all those things, protein losing enteropathy, all those things. But if urinary sodium was more than 10, it was renal failure. And the specific diagnosis as to what is the cause can be made by the specific clinical features. Like heart failure will have four cardinal features: bilateral dependent pitting edema, raised pulsatile JVP, soft tender hepatomegaly, bilateral basal fine crepitations. If the cause is nephrotic syndrome, we will have renal edema like periorbital puffiness, more in the early morning, associated with decreased urination, and all those diagnostic criteria like nephrotic range proteinuria. If it is cirrhosis, it will be associated with stigmata of chronic liver disease, and it will be associated with hypoalbuminemia. So that's how we differentiate the causes of hypervolemic hyponatremia. Now coming to what are the features of hypovolemic hyponatremia. We discussed hypovolemic hyponatremia causes were of two types, mainly renal or non-renal or extrarenal. Extrarenal causes were associated with decreased urinary sodium excretion. Renal causes of hypovolemic hyponatremia are associated with increased urinary sodium excretion. So all those can be differentiated by urinary sodium estimation. If the urinary sodium excretion is less than 10, it is a non-renal cause with working kidneys. If the urinary sodium is more than 20, it is a renal cause, and during diuretic therapy also this can happen. Among that, the specific causes we know already. Last but not the least, euvolemic hyponatremia. What are the diagnostic criteria? What is the prototype for euvolemic hyponatremia? That is syndrome of inappropriate ADH secretion. So what is the diagnostic criteria for syndrome of inappropriate ADH secretion? Absence of renal, adrenal or thyroid insufficiency, heart failure, nephrotic syndrome, cirrhosis, diuretic ingestion and dehydration. So basically all the conditions that can cause hyponatremia, all the known conditions, all the common conditions that can cause hyponatremia by other mechanisms like hypovolemic or hypervolemic, all those must be absent. That means CAD is a predominantly diagnosis of exclusion. In presence of that, the urinary osmolality must be one more than 100. Why the urinary osmolality will be more than 100? Syndrome of inappropriate ADH secretion. That means ADH will get secreted more. That means water will get retained from the urine. Water will get reabsorbed from the urine. So from the urine, the water is getting reabsorbed means urinary osmolality will be what? It will be higher. So urinary osmolality will be more. Next criteria is serum osmolality. As the water is getting absorbed more and more into the systemic circulation, what will happen to the serum osmolality? The serum osmolality will be less than 280, or serum osmolality will be lower because the water is diluting. Serum sodium, obviously the CRD is a cause of euvolemic hyponatremia, so the serum sodium will be less than 135, and urinary sodium will be more than 30. Urinary sodium will be more than 30. Why? Because the water is getting reabsorbed, not the sodium. So in the urine the same amount of sodium is getting excreted, but water is getting reabsorbed. That means the existing sodium concentration will be more. That's why the urinary sodium concentration must be more than 30. So urinary osmolality more than 100, serum osmolality less than 280, serum sodium less than 135, urinary sodium more than 30. These are the criteria for syndrome of inappropriate secretion. And last but not the least, just like in hypoglycemia criteria or hypersplenism criteria, there will be reversal of sodium wasting and correction of hyponatremia with water restriction, because the predominant mechanism in syndrome of inappropriate ADH secretion is what? Water retention. So the treatment of choice in syndrome of inappropriate ADH secretion is what? Water restriction. So if you restrict water, all these clinical features and all the laboratory criteria will normalize. So coming to the difference between cerebral salt wasting syndrome and syndrome of inappropriate ADH secretion. First, coming to the difference in pathogenesis that we have discussed earlier. Cerebral salt wasting is mainly caused by excessive secretion of B-type natriuretic peptide from the brain, that is caused by pathologies in the CNS, while syndrome of inappropriate ADH secretion is caused by inappropriately excess secretion of ADH. Volume status: the CAD is a prototype example of euvolemic hyponatremia, while cerebral salt wasting syndrome is an example of hypovolemia, because salt wasting will be there. B type natriuretic peptide will be secreted, that's why natriuresis will be there, so sodium will be excreted, equiosmolar amount of water will be excreted, so hypovolemia will be there. As there will be hypovolemia, all these parameters will get concentrated, and the concentration of all these parameters like hematocrit, blood urea, nitrogen, creatinine and uric acid, all these will be increased, while syndrome of inappropriate ADH secretion leads to retention of water, so concentration of all these parameters is decreased. Urinary sodium excretion, we discussed in the criteria that urinary sodium excretion will increase excessively because cerebral salt wasting, the name itself signifies, while in ADH secretion urinary sodium will be slightly high, mainly more than equal to or more than 30 milliequivalent per liter. Vasopressin level will be more in syndrome of inappropriate ADH secretion, while it will be decrease in cerebral salt wasting as a part of compensatory response. The urinary output will be less in CAD, or no, it may be normal because of excessive ADH secretion, but it will be high due to salt wasting with equiosmolar amount of water excretion. B type natriuretic peptide of course will be increase in cerebral salt wasting, it will be normal in CAD. And the treatment, as the pathogenesis in CAD is the retention of water, the treatment will be fluid restriction, while the pathogenesis in CSWS is excretion of sodium and excretion of water. That's why the treatment of choice will be administration of mineralocorticoid, which will cause retention of sodium. So after reading about all this about hyponatremia, the approach to hyponatremia actually becomes easier. We know that when we encounter a case of hyponatremia or when we see a lab report of hyponatremia, first thing that we should do is see the plasma osmolality, because that will help us in differentiating between a case of actual hyponatremia and cases of pseudo or factitious hyponatremia. So if we encounter a plasma osmolality of normal range, that may point towards a presence of a pseudo hyponatremia. Similarly, if the plasma osmolality is high, that may point towards the presence of hyperosmolar solutes like glucose, mannitol, all those things. But in presence of true hyponatremia, the plasma osmolality will be low. That's why it is called hypoosmolar. That's why there will be hypoosmolality. So after the first step of measurement of plasma osmolality is confirmed, the second step is, we just learned that the second step is assessment of volume status, because the hyponatremia can be classified as hypervolemic, hypovolemic, and euvolemic. So if there are pointers towards the presence of hypervolemic hyponatremia, so hypervolemic hyponatremia means there is predominant accumulation of water, fluid retention in the body, congestive cardiac failure, cirrhosis, nephrotic syndrome, renal failure. We learnt about all those conditions, and we learnt that in all of those conditions the urinary sodium will be less than 10, except one, that is one exception, that is renal failure. So we will differentiate all those causes by measuring the urinary sodium. If the urinary sodium is more than 20, it is renal failure, either acute or chronic. But if the urinary sodium is less than 10, then the causes are congestive cardiac failure, cirrhosis, nephrotic syndrome, protein losing enteropathy, all of those things. And we can differentiate between individual conditions by the specific cardinal features. On the other hand, if the patient is having euvolemic hyponatremia, the prototype condition is syndrome of inappropriate ADH secretion, and we learnt about some other conditions also. So we'll differentiate among those by measuring the urinary osmolality. We learnt that in a case of syndrome of inappropriate ADH secretion, the urinary osmolality will be more than 100. So if the urinary osmolality is less than 100, we'll think of primary polydipsia. That means euvolemic hyponatremia has happened in this child because of primary polydipsia. That means excessive intake of water only. That's why the urine is becoming maximally diluted, because the kidney will try to excrete that excess amount of water that has been taken. So primary polydipsia will have urinary osmolality less than 100. On the other hand, if the urinary osmolality is more than 100, the classical example is syndrome of inappropriate ADH secretion. Some other conditions can be glucocorticoid deficiency, hypothyroidism, stress, and specific drugs we learnt about like carbamazepine, valproate, all those things. Last but not the least, and actually the most important part, if there is features of hypovolemia, hypovolemic hyponatremia, we learnt about mainly two conditions. There can be renal loss, there can be extrarenal loss. In the cases of renal loss, the urinary sodium will be high. In the cases of extrarenal loss, the urinary sodium will be low as a compensatory mechanism. So how can we differentiate among the causes of hypovolemic hyponatremia? By measuring the urinary sodium. If the urinary sodium is more than 20, that means it indicates renal losses. So what were the renal causes? Diuretics administration, aldosterone deficiency, salt losing enteropathy, cerebral salt wasting syndrome, and renal tubular acidosis. On the other hand, if the urinary sodium was less than 10, that means extra renal loss is happening, and as a compensation the urine is kidney is trying to retain the sodium. So the extra renal causes were vomiting, diarrhea, and third space loss. This is the approach to hyponatremia in a child. Coming to the management of hyponatremia, again we will see what was happening exactly in hyponatremia and how we need to manage. Again recapitulating, this is a brain cell. There is hyponatremia outside. Hyponatremia outside means decreased osmolality or osmolality is low. If the osmolality is really low, what will happen? The water will move from outside the cell to inside the cell. That will lead to swelling of the brain cell. That will lead to clinical features suggestive of cerebral edema. But the thing is, whenever the this happens, the body always tries that, whenever this happens for a long time, the body always tries that outside the osmolality is low, so inside also I should try that the osmolality should be low, so that the osmolality inside the cell and outside the cell should be equal, so that there should be no cerebral edema. So how can the cell decrease the osmolality inside it? It will extrude some of the substances to outside which are giving rise to osmolality, like potassium chloride, organic osmoles. It will extrude some of the substances, and as a result of that extrusion, the intracellular osmolality falls and the cell decreases to normal size. This happens when the hyponatremia is chronic. So in a chronic case of hyponatremia or a chronic hyponatremia, the intracellular osmolality is also low due to the extrusion of intracellular osmotic substances like potassium chloride and organic osmoles. So for a management of hyponatremia, first we need to differentiate acute or chronic, because if it is chronic, we need to manage or we need to treat it slowly. If it is acute, we can correct it rapidly. Why? We'll learn in a bit. So chronic hyponatremia should not be corrected rapidly. It should be corrected maximum up to 10 milliequivalent per liter every 24 hours or 18 milliequivalent per liter every 48 hours. For example, if a particular person's serum sodium is 110, the lower limit of serum sodium in a normal range is 135, doesn't, and the patient is having chronic hyponatremia, doesn't mean that we'll correct the sodium from 110 to 135. That means 25 in one day. If it is chronic hyponatremia, maximum that we can correct in one day is 10. That means we'll go from 110 to 120 in one day, 120 to 130 in another day, then 130 to 135 slowly. Next, if the hyponatremia is acute, we don't need to worry about all that. Documented acute hyponatremia. We have documented a serum sodium of 134 today. Tomorrow we document that the serum sodium is 120, fall by 14 in one day. So that is a documented hyponatremia, documented acute hyponatremia. In that case, we don't need to worry about the speed of correction. If the patient is symptomatic, we can correct it over one day, and it can be corrected by administration of 3% saline or hypotonic saline. If there are seizures due to cerebral edema, we need to correct it more rapidly. So because the seizures due to hyponatremia have poor response to anti-epileptic drugs, so we need to give them 3% saline bolus at 4 to 6 ml per kg over 1 hour, irrespective of the serum sodium, because it is symptomatic and can cause death of the child. And hypoxia always worsens the cerebral edema, so hyponatremia exacerbates the hypoxic cell swelling. That's why oxygen inhalation in a patient having hyponatremia also can help. So what exactly is osmotic demyelination syndrome? Will come again. The brain cell is here, and the outside sodium is low. That means the osmolality is low. That means the H2O will move from outside the cell to inside the cell. The brain cell will swell, and if this persists for a long time, chronic, more than 48 or more than 72 hours, then the cell will try to decrease its osmolality inside. So what the cell will do? The cell will extrude potassium chloride and organic solutes to outside, so that the intracellular osmolality will be gradually less. So in the case of chronic hyponatremia, the intracellular osmolality is low. Intracellular osmolality is low because of extrusion of all these solutes. So suppose in this case we give rapid infusion of hypotonic saline or 3% saline. So what will it cause? It will cause rapid increase in extracellular osmolality. But imagine, extracellular osmolality is rapidly high now, but the intracellular osmolality is low. So what will happen? Again the water will move from inside the cell to outside the cell. So as the water will move from inside the cell to outside the cell, because of the rapidly increased osmolality outside the cell will further shrink. As the cell shrinks, the brain cells will detach from the meninges, the brain cells will detach from the blood vessels in the brain. As a result, there will be osmotic demyelination syndrome. There will be intracranial hemorrhages and all those things. So osmotic demyelination syndrome is characterized by a biphasic course, because there is transient initial neurological improvement followed by deterioration over the next 2 to 7 days. The characteristic clinical findings are mutism, dysarthria, confusion, agitation, quadriparesis, and pseudobulbar palsy. These are the classic manifestations of osmotic demyelination syndrome. So in a case of chronic hyponatremia, if you correct the hyponatremia too rapidly, it can lead to osmotic demyelination syndrome, which can present in this way. So management of hypovolemic hyponatremia was primarily due to increased loss of body water. So what deficiency of sodium and plus or minus water. So what it will be its management? We have to replace the sodium deficit, because the primary problem was deficiency of sodium. We have to replace the sodium deficit, and if any water deficit is present, we have to replace that also. So we have to restore the intravascular volume with isotonic saline or normal saline, which will suppress the ADH secretion and which will lead to excretion of the excess water that will lead to the correction of hyponatremia. Management of hypervolemic hyponatremia. Hypervolemic hyponatremia, fluid retention was there, chronic kidney disease, acute renal failure, congestive cardiac failure, cirrhosis, all those conditions. So what will be the management in those conditions? There will be water and sodium restriction. We have to do water and sodium restriction so that the fluid accumulation doesn't aggravate further. That is the cornerstone of therapy. We may require some diuretics so that some amount of sodium and water both will be excreted, and bhaptans have some role because they block the ADH and cause the water diuresis, but those are contraindicated if the moderate to severe CNS symptoms are present. Last but not the least, if nephrotic syndrome is there with severe hypoalbuminemia, we may need to transfuse 5% or 10% or 25% of albumin followed by a diuretic. If there is renal failure, that was the one exception of hypervolemic hyponatremia in which the urinary sodium was high, we will need to give fluid restriction, and if critical or not, we are not able to restrict the fluid while maintaining the nutrition, we may need to take the patient for. Coming to the management of euvolemic hyponatremia, the euvolemic hyponatremia, the prototype cause was syndrome of inappropriate ADH secretion, in which the main pathogenesis was water retention of excess water because of excess ADH secretion. So the goal of treatment is eliminating the excess water. If we do not eliminate the excess water also, in some conditions it may correct spontaneously over the next 3 to 6 hours, but whatever may be the cause, whatever may be the mechanism, whatever may be the duration, if the patient is having symptoms and acute, we may need to administer 3% saline to the patient to reverse the cerebral edema. If the patient is having iatrogenic euvolemic hyponatremia, we may need to give 3% saline if the patient is symptomatic. Further management will depend upon the volume status. Lastly, if the patient is having syndrome of inappropriate ADH secretion, the treatment of choice obviously is fluid restriction because the pathogenesis is fluid accumulation caused by excess ADH secretion. Some resistant cases may require furosemide and sodium chloride administration or normal saline supplementation. Baptans have a questionable role. But if the patient is having asymptomatic chronic hyponatremia, as we discussed before, we need to correct the hyponatremia slowly, because if we correct rapidly, there will be osmotic demyelination syndrome. So we have to think about treating the underlying etiology always. We have to correct the sodium by calculating the sodium deficit. The sodium deficit is calculated like this: 130 minus the serum sodium into multiplied by 0.6 multiplied by the body weight. Suppose the serum sodium is 115, so this will come to be 15 into 0.6, that will be 9 into body weight. Suppose the body weight of the child is 60, so it will be coming to 9 into 60, that is 540. So we have to calculate the sodium deficit in milliequivalent, then we have to change the milliequivalent to ml by multiplied by 2, because 1 ml of 3% saline contains 0.5 milliequivalent of sodium, and that amount of uh, so see, hypotonic saline we have to give slowly. Now coming to hypernatremia, if you have understood the mechanism and the etiologies of hyponatremia that we discussed, you can easily understand the etiology, mechanism, clinical features of hypernatremia, because all of those are similar. Hypernatremia, the definition is serum sodium more than 145 milliequivalent per liter. Three basic etiologic mechanisms are there. Sodium is more in the body. That's why the etiologic classification can be three types. Either the hypernatremia is due to sodium intoxication, that means excess sodium, or the hypernatremia may be due to water deficit, that means water is getting depleted from the body, as a result the sodium concentration is increasing, or water and sodium deficit is there, but the water deficit is more than the sodium deficit. So that is basically the mechanism of hypernatremia. Three basic mechanisms are there. So coming to the first mechanism, sodium intoxication. Sodium intoxication means there is excess sodium chloride or excess sodium inside the body. So where from it will come? It may come from iatrogenic causes like correction of metabolic. Suppose the patient is having metabolic acidosis, and you have corrected by giving sodium bicarbonate. So that bicarbonate will correct the acidosis, but the sodium will get accumulated. So that patient will have sodium overload or hypernatremia. How you can diagnose that? Because if you have given excess sodium bicarbonate, this patient will be accompanied by profound metabolic alkalosis caused by the sodium bicarbonate. Similarly, what other causes can be there? If you have given IV hypotonic saline to a particular patient, so that may lead to increase in serum sodium. if you have given excessive baking soda is same as sodium bicarbonate. So baking soda is commonly taken for upset stomach, and it is associated with profound metabolic alkalosis similar to the first mechanism. What can be the other causes? Hyperaldosteronism. Increased amount of aldosterone in the body will cause increased sodium retention and potassium excretion, so that will lead to hypernatremia in the child. Improperly mixed formula, under dilution. If you have prepared a formula for the child but you have under diluted, for example, if you mix 1 scoop of powder or formula with 30 ml of water, that is adequate. But if you mix 1 scoop with suppose 10 ml of water, that will lead to increasingly concentrated or under diluted formula, that can give rise to hypernatremia. And ingestion of seawater or sodium chloride, some people who do a lot of swimming or due to some other cause, if they ingest a lot of seawater, and that contains sodium chloride obviously, so that can lead to hypernatremia. And Munchausen by proxy, if some caretaker or parent is abusing the child or by giving intentionally increased amount of salt, that can lead to hypernatremia also. All these conditions of hypernatremia are caused by sodium intoxication, that means excess sodium retention in the body. Next, coming to the second mechanism, that is water deficit. Water is getting depleted from the body. As a result, the sodium is getting more concentrated. So the sodium concentration is increasing. So predominant or prototype cause is nephrogenic and central diabetes insipidus. So what happens in diabetes insipidus? In central diabetes insipidus, the ADH is not secreted. In nephrogenic diabetes insipidus, the ADH is not able to work due to resistance at the receptor level. So whatever may be the cause, the ADH is not able to implement its action. So ADH is not able to implement its action means water will get excreted. So water will get excreted means the total body water will get decreased, but it is not hampering the sodium. So total body sodium remains the same, but the total body water decreases. So as a result, what will happen? Hypernatremia will happen. So that is the predominant cause. What is the second cause? This nephrogenic and central diabetes insipidus may be acquired, may be X-linked, may be autosomal dominant, may be autosomal recessive, and it may be a part of Wolfram syndrome, that is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So what other causes may be there? What in which water deficit will happen? Prematurity due to excess insensible water loss. Radiant warmer, administration of radiant warmer or giving radiant warmer to a newborn baby due to excessive insensible water loss. Administration of phototherapy to a baby will lead to increased insensible water loss. So all these conditions will lead to increased insensible water loss. Water loss, that means water deficit, so sodium will get concentrated. Hypernatremia. Inadequate breastfeeding, child neglect, similar mechanism, water is getting lost. And adipsia, that means whatever may be the reason, may be due to a trauma to hypothalamus or tumor in a hypothalamus or hydrocephalus or histiocytosis, the person is not drinking water. So due to the water deficit, the sodium will get concentrated and it will lead to hypernatremia. So last cause, that is water and sodium deficit. Water and sodium are both deficit in the body, but the water deficit is more than the sodium deficit. That's why the hypernatremia is happening. So what can be the cause? That water and sodium deficit may be lost from the GI, may be lost from the kidney, or may be lost from the skin. So we have to think about causes in which the GI tract loses water and sodium, the kidney loses water and sodium, the skin loses water and sodium. So you can guess the causes by now. Diarrhea, emesis, osmotic laxatives, all these conditions are causing gastrointestinal loss of water and sodium, but the water lost is more than the sodium loss. That's why there is hypernatremia. Similarly, what can be the causes of renal loss? Osmotic diuretics, diabetes mellitus, chronic kidney disease, polyuric phase of acute tubular necrosis, post obstructive diuresis. All these conditions, there is renal loss of water and sodium both, but the water loss is more than the sodium loss. That's why there is hypernatremia. And the last is cutaneous loss. You can think in which cutaneous loss will be there. Burns, there is excessive cutaneous loss. Excessive sweating, classically in cystic fibrosis, there will be excess water loss, excess sodium loss. But if when the water loss will be more than the sodium loss, there will be hypernatremia. So what is essential hypernatremia? Essential hypernatremia is caused by injury to hypothalamic posterior pituitary axis. It is a euvolemic hypernatremic condition. The patient is usually non-hypertensive as signified by the euvolemia. The patient may have some hypodipsia, that means decreased intake of water, that is essentially leading to the hypernatremia. This hypodipsia is due to the reset osmol sensor. Osmol sensor means the same osmoreceptor. Usually when the osmolality falls, osmolality increases or the effective circulating volume falls, the osmoreceptor should get stimulated. But if when the osmolality is increasing or effective circulating volume is decreasing, still the osmoreceptor is not getting stimulated, the thirst will not get stimulated. That means osmolality will keep on increasing. So that will lead to essential hypernatremia, and it is very rare in children. So coming to the clinical manifestations, similar to hyponatremia, we'll discuss. Imagine this is a brain cell or any cell in the body. Basically, there is hypernatremia. That means the extracellular osmolality is high. So extracellular osmolality is higher than the intracellular compartment. So what will happen? The water will move from the inside the cell to outside the cell. So when the water will move from inside the cell to outside the cell, what will happen? The cell will shrink. So cell will shrink means it will detach from the detach from the meninges, detach from the blood vessels. So basically all the clinical features of intracranial hemorrhage can happen in a case of acute onset hypernatremia. But if you think the main clinical manifestation of hypernatremia are due to hyponatremia were due to the decreased plasma osmolality. Similarly think what will be the clinical features of hypernatremia. Think this is a case of hypernatremia. In this case of hypernatremia, excess water is coming from inside the cell to outside the cell, and in return the cell is shrinking. That means the water will be predominantly segregated in the extracellular compartment or the intravascular compartment. So there will be a relatively better preservation of intravascular volume, and the BP and urine output will be maintained for a long time irrespective of the hypernatremia. Why the BP and urine output will be maintained? Because the excess water is coming from the inside the cell to outside the cell, that is maintaining the plasma volume or intravascular volume. But this maintenance of blood pressure and urine output is at the cost of intracellular dehydration, because this BP is being maintained by the water that is coming from inside the cell. So this maintenance of blood pressure and urine output will come at the cost of intracellular dehydration. So when there will be cellular dehydration, what will happen? There will be a doughy feeling of the abdominal skin on pinching, as if there is severe dehydration, and in long term the CNS symptoms like high pitched cry and hyperreflexia will be there, and it may be associated with hyperglycemia and hypocalcemia. So as we discussed, the brain cell will have hyperosmolarity outside. Hyperosmolarity will be outside means the water will move from inside the cell to outside the cell. That will cause the brain to shrink. So there will be clinical features of brain hemorrhage, because there will be tearing of the intracerebral veins and bridging vessels, because the cell is getting detached from the meninges, detached from the vessels. So any type of hemorrhage can happen, basically subarachnoid hemorrhage, subdural hemorrhage, parenchymal hemorrhage, and which will lead to seizures and coma, and there may be thrombotic complications. Why thrombotic complications? All this hypernatremia will cause polycythemia, so that will lead to thrombotic complications, which are manifest by stroke or thrombosis of the dural sinus or renal vein thrombosis. So how will you diagnose a case of hypernatremia? First, obviously, is the history. From the history, we have to think about if we can get some specific etiologies diagnosed directly. So if there will be water deficit, only if no access to water or the patient is unable to drink, in that case water deficit will be there. And as the water is deficit, the body will always try that I will excrete less and less sodium through the urine, so that sodium will get retained in the body as well as water will get retained in the body. So in that condition, there will be a low fractional excretion of sodium. Second mechanism, sodium intoxication. How will ask about sodium intoxication? We have to ask about the sodium intake. What are the signs of dehydration? Usually will be absent. Because why the signs of dehydration will be absent? Because we just learned that in a case of hypernatremia, the intravascular volume and the urine output will be maintained at the cost of intracellular dehydration. So unless and until severe hypernatremia happens, the manifestations of dehydration will not be apparent. And when there will be severe intoxication, patient may have symptoms of volume overload like pulmonary edema and weight gain. Why the volume overload? Because excess water will be coming from inside the cell to outside the cell, so there will be volume overload. And when there will be salt poisoning, when there will be salt poisoning means the patient has taken excess amount of salt, so body will try to do what? The kidney will try to excrete that excess amount of salt. Body cannot excrete, or kidney cannot excrete fresh crystals, it will excrete the salt by urine, dissolved in urine. So the fractional excretion of sodium through the urine will be slightly higher in that case. If there is hyperaldosteronism, the patient may have features like edema, hypertension, hypokalemia, and metabolic alkalosis. So remember, we learnt about the intracellular fluid compartments, extracellular fluid compartments, and all those things. So before knowing about the diagnosis, we need to understand this. The intracellular fluid constitutes around two-thirds, and extracellular fluid constitutes around one-third. So when there will be free water loss means pure water, there is no solute inside. There is no solute inside means if there is free water loss, this free water loss will also be in proportion to the intracellular and extracellular fluid ratio. That means suppose 100 ml of free water loss is there, 60 ml will be lost from the intracellular fluid, 40 ml will be lost from the extracellular fluid. Why? Because of that two-third, one-third ratio. So there will be relatively less compromise of each compartment. But suppose a fluid was being lost which was having same composition as the intracellular fluid, the intracellular fluid compartment will get more compromised, rather the extracellular fluid compartment will be preserved, and vice versa. So how do we diagnose hypernatremia? If there is isolated water loss, these type of features will be there. That means isolated water loss will lead to proportional decrease in intracellular and extracellular fluid. There will not be predominant decrease or isolated decrease from one compartment. So if there is isolated water loss, the clinical features will not manifest early, the clinical features will manifest late, because neither the extracellular fluid compartment is compromised so much, nor the intracellular fluid compartment is compromised so much. So there comes the second line that I am going to tell now, that the signs of volume depletion are less severe, that is loss from the intracellular space. So isolated water loss will have signs of volume depletion that are less severe, but if signs are present, that means so much amount of fluid has been lost. That means the more severe the dehydration, the signs will be present. Maximally concentrated urine will have more than 1000 milliosmol per kg of osmolality. So if there is maximally concentrated urine and the low volume urine, that means suppose the kidney is excreting very low amount of urine which is maximally concentrated. Why the kidney is doing that? Because the kidney is doing that as a part of compensatory response so as to preserve the water, because the body is having hypernatremia. Imagine if a patient is having hypernatremia, the body will try to conserve more water so that the hypernatremia gets diluted to a normal sodium level. So what will the kidney do? The kidney will excrete less and less amount of urine. It will actually excrete the least amount of urine possible, or least amount of urine volume allowed to excrete the solute load from the body. So the urine volume will be low and the concentration of the urine that is excreted will be high. So that will be present in a case of extrarenal loss or inadequate intake. On the other hand, if the patient was having renal loss of sodium and water, what will happen? The normal urine volume will be there, or urine volume may actually be high, and the urine volume will be diluted, because diluted urine excretion will lead to purely water excretion. The sodium will be retained in the body, so the sodium concentration will increase, so that will lead to hypernatremia. So if there is, we discussed about isolated water deficit, now we discuss about combined sodium and water deficit. If there is combined sodium and water deficit, we learned that combined sodium and water deficit happens in three conditions. The water and sodium deficit may be happening, or loss may be happening from the GI tract, maybe from the kidney, and maybe from the skin. So similar to hyponatremia, we can differentiate that by urinary sodium excretion. If the urinary sodium excretion is low, that means the urine is conserving the sodium. So that means the loss originally is from a non-renal pathology, so that the kidney is compensating. That means in extra-renal loss, the urinary sodium will be less than 20. On the other hand, if the renal loss is there, that means the sodium and water that is being excreted is from the urine only, or is from the kidney only. That's why in this condition, the urinary sodium will be more than 20. We have discussed this before. So now coming to the approach to hypernatremia. If the patient is having hypernatremia, obviously the first step is to assess the volume status, because The patient may be having hypovolemia, hypervolemia, or euvolemia. If the patient is having hypervolemia, think hypernatremia with hypervolemia. So obviously hypervolemia implies increased water in the inside the body, or increased fluid accumulation inside the body. But if isolated fluid was getting accumulated inside the body, the patient would be having hyponatremia, not hypernatremia. That means the coexistence of hypernatremia and hypervolemia actually indicates that the hypernatremia is the primary thing that is causing equiosmolar amount of water retention inside the body. That means the original or primary pathology is actually sodium gain, which is causing some amount of water gain also. So that means all these conditions can be due to increased sodium gain. That sodium gain may be due to enteral intake by the patient himself, or it may be due to hypotonic saline administration at the iatrogenic level, or it may be due to sodium gain due to hyperaldosteronism, that means increased aldosterone action. And as the sodium is being gained inside the body, what will the body's compensatory mechanism do? The body's compensatory mechanism will try to excrete the increased excess amount of sodium from the body by the kidney. So all these conditions will have urinary sodium of more than 20. On the other hand, if the patient is having hypovolemia, hypovolemia means water is getting lost from the body. As there is water deficit from the body, the remaining sodium is getting concentrated, and as a result there is hypernatremia. So this is actually simple. So increased water loss can be from the renal site or from the extrarenal site, and obviously we can differentiate between those two by doing the urinary sodium. If the urinary sodium will be more than 20, that means the sodium loss is from the renal site only. That means renal losses like diuretics or polyuric phase of acute tubular necrosis. And when the urinary sodium is less than 20, that means the kidney is trying to retain the sodium as a compensatory mechanism. That means the primary pathology is not inside the kidney, it is outside the kidney. That means extrarenal losses like GI loss or excessive sweating. Lastly, if the patient is having euvolemia, that means there is volume status is remaining normal in this child. So what can be the causes? Those causes can be differentiated by doing the urinary osmolality. If the patient is having urinary osmolality of more than 800, that means urine osmolality is more than 800, means patient is excreting an increasingly concentrated urine. So when the patient will excrete increasingly concentrated urine, when there is other sources of loss from the body like in excessive sweating or excessive insensible water losses. So already there is excessive water loss from the body from other sides, so kidney cannot be allowed to excrete a lot of amount of urine, because that will lead to further water deficit from the body. So the kidney is trying to retain some amount of volume inside the body as a compensatory mechanism by excreting a concentrated urine. So that is causing the urinary osmolality of more than 800. So what are the causes? Extrarenal losses like insensible water loss and respiratory loss. And lastly, if in this condition of euvolemia, if the urinary osmolality is less than 800, that means the patient is excreting a dilute urine. The patient is excreting a dilute urine. As a result, the increasing water loss from the body is causing the concentration of the remaining sodium inside the body to rise, so that hypernatremia is happening. And obviously, the increasingly excess excretion of dilute urine is caused by diabetes insipidus. So this is the approach to hypernatremia in a child. So this is another approach to hypernatremia in a child. The same thing we discussed, that but presented in a more slightly complicated manner. So how to manage hypernatremia? Similar to what we discussed. Imagine this is the brain cell, and the sodium concentration outside the brain cell is much higher. So when the sodium concentration outside the brain cell is much higher, what will happen? The extracellular osmolality will be higher. So what will the water do? The water will move from inside the cell to outside the cell. Water will always move from an area of hypoosmolarity to a hyperosmolarity. So what will happen to the brain cell? The brain cell will shrink. So in this condition, if this condition persists for a long time, what should the brain cell do? The brain cell will try that, okay, outside myself this osmolality is higher, so I should also do something so that my intracellular osmolality also should increase, so that it equilibrates with the extracellular osmolality. So how can the brain cell do that? The brain cell will give rise to production of idiogenic osmoles. The production of idiogenic osmoles inside the cell will give rise to slightly increased osmolality inside the cell, that will lead to relative normalization of the brain cell size. As the brain cell size relatively normalizes over a long period of time, this equilibrium or state of equilibrium will be maintained. So when hypernatremia will be there, similar to hyponatremia, we have to first differentiate whether it is acute hyponatremia or chronic hyponatremia, because if it is acute, we can correct it rapidly with distilled water or 5% dextrose. But if it is chronic, we cannot correct it rapidly. Similar to hyponatremia, we can correct it maximum 10 to 12 milliequivalent per liter over the initial 24 hours, and the initial restoration of intravascular volume has to be always done by normal saline. Ringal lactate is contraindicated as it is hypotonic. If there is depletion of intravascular volume, we have to always replace this with normal saline. Frequent monitoring obviously is very important, because rapid correction in chronic hypernatremia can lead to devastating manifestations. If there is sodium intoxication causing the hypernatremia, we can do dialysis plus or minus loop diuretics so that the sodium will be getting excreted, and we have to address the underlying cause. For example, if it is central diabetes insipidus, we may give desmopressin acetate. If it is nephrogenic diabetes insipidus, we have to decrease the sodium intake and we have to give some specific drugs. So what is the speed of correction? I told that maximum we can correct 10 to 12 inside 24 hours. So suppose if we think that the upper limit is 145 milliequivalent per liter, if the serum sodium is persisting between 144 to 157, there is gap of 12, so we can correct it within 24 hours. If it is between 158 to 170, that means another 12, we can correct it between 48 hours. If it is 171 to 183, another 12, so we can correct it over 72 hours. If it is between 184 to 196, that means another 12, we have to correct it over 96 hours. This is in case of chronic hypernatremia. So what will be the treatment of hypernatremic dehydration? Always the type of fluid has to be N by 2 saline or half normal saline with 5% dextrose. Why half normal saline? Because already the patient is having hypernatremia. So we have to give a solution that is hypoosmolar. We have to give a solution that has concentration of sodium less than the body requires. That's why we are giving here half normal saline plus 5% dextrose, and potassium chloride has to be added unless and otherwise it is contraindicated. Some infants may require dextrose 5% dextrose with n by 3 or n by 4 or n by 5 normal n by 5 saline. And what will be the rate of fluid? The total amount of fluid or rate of fluid has to be 1.25 to 1.5 times the total maintenance fluid usually required for the child. That means we have to give some excess amount of water so that the concentrated sodium that is present inside the body gets diluted. We have to follow up closely and monitor because of the possible side effects of rapid correction. We have to do troubleshooting like this. If the signs of volume depletion appear, suppose you are correcting a patient of hypernatremia and signs of volume depletion are appearing, so forget about hypernatremia. Volume depletion is acutely dangerous, so we have to give normal saline bolus at 20 ml per kg over 20 minutes to restore the volume depletion first. Similarly, suppose you are correcting the sodium of a person having hypernatremia and the sodium falls too quickly. In a chronic hypernatremia, the sodium falls too quickly. If the sodium falls too quickly, it can cause osmotic demyelination syndrome like in hyponatremia. So we have to change the treatment so that the sodium doesn't fall too quickly. How can we do that? We have to increase the sodium concentration in the IV fluid we are giving, or decrease the rate of IV fluid that we are giving, so that the sodium doesn't fall too quickly. And vice versa, if the sodium falls too slowly, it may take very long time, it may cause clinical features or symptoms of hyponatremia. So we have to make sure that the sodium falls slightly more rapidly. So how can we do that? We can decrease the sodium concentration of the intravenous fluid or increase the rate of IV fluid. And obviously we have to replace the ongoing losses as they occur. So how we can do that? This is a recommended this is a general suggestion. We can connect the baby to two sets of IV fluid. One is N by 2 D5, one is DNS. So and we have to give the fluid by two simultaneous drip lines. Suppose the sodium falls too quickly. Sodium falls too quickly means we don't want that. We just want the sodium to fall slightly more slowly. So we can give N by 2 D5 more slowly and DNS slightly more rapidly. So what we have done, we have increased the concentration of the sodium, increased the concentration of sodium inside the IV fluid. Vice versa, if the sodium falls too rapidly, if the sodium falls too slowly, the sodium falls too slowly means we have to cause it that the sodium falls slightly more rapidly. So how we can do that? We have to decrease the rate of DNS and increase the rate of N by 2 D5, so that we have decreased the concentration of sodium in the parenteral fluid. So what are the clinical features of impending cerebral edema? You can see the NCCT pictures here. There is cerebral edema, there is loss of gyri and loss of sulci inside the brain. So what are the features of impending cerebral edema? Seizures, depressed level of consciousness, all these can indicate an impending cerebral edema. Whenever there will be impending cerebral edema, we have to acutely administer 3% saline bolus so that the cerebral edema doesn't happen, or if at all if it is happening, it can not progress. So we have to give the 1 ml per kg of 3% saline can cause increase in sodium by 1 millicoin per liter, and an end dose of 4 ml per kg can cause the resolution of symptoms, similar to the treatment of symptomatic hyponatremia. So as we have discussed about hyponatremia and hypernatremia in detail, it is better if we discuss one or two case scenarios. So, case scenario 1, a 3-day-old male baby has come to you with a history of perinatal asphyxia and no convulsions. So, most probably the child is having HI1, poor feeding on OG2 feeding, vital stable, the pulses are good, there is adequate urination. Routine laboratories were sent on day 3, which has revealed a sodium of 118. So, what is the diagnosis? So, obviously, we'll think about history first. If you think about history, in a newborn baby with a background of perinatal asphyxia having serum sodium of less than 118, the diagnosis is actually clear from this only. This is a case of syndrome of inappropriate ADH secretion. So if we see the flow chart also, we assess the serum osmolality as it is a case of true hyponatremia. So most likely the patient will have low osmolality. Then we assess the volume status of the child. The patient is having euvolemia as indicated by normal urine output, normal pulses, normal peripheries, all those things that I have mentioned in the case scenario. And next, to confirm, we have to do the urine osmolality. It should be more than 100. Serum osmolality should be less than 280. Urinary sodium should be more than 30. All those criteria of CRD will be satisfied, so that the diagnosis of syndrome of inappropriate ADH secretion will be made. How will manage this child? It is common in the background of perinatal asphyxia. We have to confirm the diagnosis by the diagnostic criteria, which can be done by measuring the serum osmolality, urine osmolality, and urinary sodium. And the treatment of choice is fluid restriction. Coming to the case scenario 2, a day 2 male child having history of parental asphyxia, currently intubated because of impending respiratory failure and severe metabolic acidosis, now maintaining saturation on mechanical ventilation. There is mottling, there is prolonged capillary refill time, 2 normal saline boluses have been given, 1 unit of whole blood has been given for severe anemia. Now currently the patient is having adrenaline going on at 0.1 for shock, and the lab reports have revealed serum sodium of 123, potassium of 6.1, calcium of 6.3. What next? So if you think this case scenario is almost similar to the case scenario 1, so you can think that okay, perinatal asphyxia, the patient is having shock, all those things. So patient is most probably a case of HI3 because the patient is having intubated, the patient is being intubated due to impending respiratory failure. There is poor respiratory drive. In a background of perinatal asphyxia, the patient is most probably having syndrome of inappropriate ADH secretion only. But the treatment of choice for syndrome of inappropriate ADH secretion is fluid restriction. But the patient is having mottling, prolonged capillary refill time, NS boluses have been given, severe anemia is having, so whole blood has been given, adrenaline is going on. So what next? The thing I want to point here is this is a case of CRD in fluid refractory shock. So we have to continue 100% maintenance IV fluid. We cannot restrict fluid in this child because the patient is having shock. So the maintenance of vital parameters takes precedence over maintenance of electrolyte in the patient. So we cannot restrict fluid in the child. Preferably, we should give total parenteral nutrition with required concentration of all the electrolytes, protein and glucose in the fluid. We should not restrict the fluid in this child, and if TPN is unavailable, we may try increasing the sodium concentration of the maintenance IV fluid with added calcium and close monitoring for potassium overload because the patient's potassium was slightly high. Case scenario 3. A 3-year-old male child has come to you with a clinical history of polyuria, polydipsia, and no dysuria, normal blood pressure, questionable similar history in the grandfather, normal urinalysis, no UTI, urinary osmolality has revealed 650 milliosmol per kg, urea and creatinine are normal, sodium is 174, potassium is 3.6. What next? So polyuria, polydipsia, and no dysuria. That means urinary tract infection has been ruled out. Most likely the patient is not having diabetes mellitus. That's why it has, because it has not been mentioned. So assuming that normal glucose has been documented, we can rule out diabetes mellitus. The patient is having normal blood pressure. That means this is a case of euvolemic hypernatremia, not hypervolemic, not hypovolemic. It's a case of euvolemic hypernatremia. Urinalysis is normal and urine osmolality is more than 650 milliosmol per kg. So coming to the approach to hypernatremia, the flowchart of hypernatremia that we discussed, obviously we assess the volume status. The volume status of the child is normal in this case because normal blood pressure, no signs of fluid overload, so euvolemia, and the urinary osmolality is less than 800. So most likely this is a case of diabetes insipidus. So most likely this is a case of diabetes insipidus. We have to confirm the diagnosis by performing the water deprivation test or desmopressin challenge test to determine the type. Neuroimaging and other relevant investigations to determine the etiology have to be performed, and the specific treatment obviously will depend upon the etiology. This is the flow chart for water deprivation test that we may follow. Coming to the last case scenario, that is case scenario 4, an 8-year-old boy has come to you with complaint of diarrhea and vomiting for 3 days with decreased urination. The GCS of the child is 9/15 and plan C correction of dehydration is going on. Emergency laboratories you have sent. You just received the report in the ICU. We are holding the report which says serum sodium of 167 milliequivalent per liter. Just now, the parents call you in anxiety that the child is unresponsive and there is no palpable pulse. You go to the patient, you see that the patient is having no palpable pulse and the patient is unresponsive. And you look at the monitor and you see this rhythm. What will you think? Take 1 minute to think what you will do next. Serum sodium is 167. So the point I want to make here is, this is a normal sinus rhythm. As you can see, this is a normal sinus rhythm. There is no premature ventricular complexes or premature atrial complexes or no arrhythmia. The rhythms are regular, nothing. In a case of no palpable pulse, if the patient is unresponsive, obviously the diagnosis is pulseless electrical activity, and the pulseless electrical activity is a cardiac arrest rhythm because the patient is unresponsive now with no palpable pulse. So the patient is having, or the patient is in cardiac arrest. So it's a cardiac arrest rhythm which is non-shockable. So you have to think immediately about calling for help, activating the emergency response system as per the PULSE guideline or pediatric advanced life support guideline. Begin high quality CPR immediately with positive pressure ventilation and 100% oxygen. Ask others to keep adrenaline injection and defibrillator ready and follow the PULSE protocol. The point I want to make here is, when you are having cardiac arrest, don't think about sodium and all those things. The vital parameters always take precedence. So what are the take home messages that we take from today's long lecture? Treat the emergencies first. Irrespective of the serum sodium, treat shock with a bolus if applicable, and the bolus always has to be normal saline irrespective of the serum sodium. Even if it is 100, serum sodium is 100, even if the serum sodium is 200, the bolus for a shock always has to be normal saline. Try to find out the onset. Determining the acuteness or chronicity of the condition the will tell you or will guide you how to manage and how rapidly you have to manage the condition. And whenever you don't know whether it is acute or chronic, always assume chronic, because the rapid management or rapid correction of chronic hyponatremia or hypernatremia can have devastating complications like osmotic demyelination syndrome. Be cautious when chronic, especially when the hypernatremia or hyponatremia is chronic. We have to correct it slowly, especially when it is chronic. Try to diagnose the cause. Do not always think that I have this is hyponatremia, I will give more sodium, hypernatremia, I will give more water. Do not think like that. Always try to diagnose the cause, because the proper management, proper and permanent management depends upon the cause. Hyponatremia is not equal to hypertonic saline administration. We are always in the tendency that whenever we see hyponatremia, what we do, we ultimately end up giving 3% saline. That is not the treatment. Some cases of hyponatremia like CRD we learned have the management of choice, which is fluid restriction. So hyponatremia doesn't always mean hypertonic saline administration. We have to find out the cause of the hyponatremia, and accordingly we have to institute the specific therapy. And no one is perfect, but we all can try. Do not ever utter the word of 3% NS or 3% normal saline. There is no such thing. This is not 3% normal saline. This is 3% saline or hypertonic saline. Normal saline is 0.9%. Hypertonic saline is 3%. There is no such thing as 3% normal saline. Thank you for your patient listening today. If you want to get more such lectures in the future, hit like, subscribe, and share with your friends. Thank you.